Good afternoon. How's the attention out there? I'm speaking to you today about strengthening community systems to increase access to antiretroviral treatment and integrated TB/HIV care in one municipality in South Africa. The outline, I'll briefly look at background and overview of the program, partners, key activities and results, lessons learned and best practice, challenges, and then some future of the program, scale up. Utugela That's It project was located in Utugela district of KwaZulu-Natal, just under Lesotho. It's the blue area. Background in terms of TB and HIV in South Africa. South Africa has the 5th highest number of TB cases worldwide, and the HIV prevalence in new TB cases is 73%. The mortality at 231 per 100,000 population, it's higher now, reports the highest number of confirmed multiple drug-resistant and extreme drug-resistant TB cases in the Southern Africa region. KwaZulu-Natal is one of the 9 provinces in South Africa, and it's got the highest new smear-positive pulmonary TB incidence in South Africa at 338 per 100,000. And our HIV antenatal prevalence is 38.7, and general is 18%. So the TB epidemic that we're currently having in South Africa is driven by HIV and poverty. Utugela district is predominantly rural and scattered, 72% unemployment. Prevalence in TB cases in our district is 78.5, and latest stats is 82. And the project, though, worked in 2 of 5 municipalities, but I will be speaking about one municipality where it lasted longer, and that in that municipality, Okaklamba, it was within 9 clinic catchment areas and 1 district hospital. An overview of the program. The That's It project was developed and branded by the Medical Research Council of South Africa. It stands for tuberculosis, HIV/AIDS treatment support and integrated therapy. The pilot was initiated in a TB hospital in Richmond, and World Vision was invited by the Medical Research Council to initiate one of the 8 rollout sites, and we changed it from a hospital-based model into a community-based model. And as a sub-grant, we only had 2 years of funding, so the program extended from June 2007 to September 2009. The aim was to increase ART for TB patients and improve integration of services at all levels. And the program had a facility component, clinic and hospital, a community-level intervention, which I will be speaking about, and the community and the facility linked through a referral system. The center of our model was what we call referral networks. And the referral network is a network of community resource people committed to visiting and supporting people on treatment, both HIV, TB, or both treatments. It's formed out of community health workers, home-based caregivers, traditional health practitioners. That's one of our big victories, is we had very good cooperation, and in our area, traditional health practitioners are often the first point of care seeking. Also youth members, faith-based and community-based organizations, and we also have the models earlier spoken about, Churches, Channels of Hope, and CCCs, and they link into the referral network also. The referral network is enrolled, then trained, and then supported to work at household and community level through World Vision in partnership with Department of Health. And they act as a referral between the household, the community, and the facility. You can see in the diagram that with the referral network, and with TB, we have moved from compliance to using the same lessons that we learned with antiretroviral that we need to move from compliance to adherence and not police patients, but support them in continuing treatment. So with a patient, with the referral network, there are now 3 levels of contact between the health facility and the patient, including the patient themselves. We initiate referral networks through tapping into social capital. It starts by running a 2-day interest workshop where everyone that is working as a community-based worker is invited and then asked would they like to engage in supporting patients to take treatment. And out of those that come forward, the clinic staff then choose 30 or 40 per clinic catchment area. The World Vision then trains them intensively in TB, HIV, in positive living, in infection control, referral. And then they have clients or patients assigned to them. They visit households, encourage patients to go for testing to adhere and address barriers of stigma, especially in the home and in the community. They encourage family members to support patients, and they help Department of Health with tracking patients, facilitate prevention and care at the home. And I think one of the strengths of the model here, this model in particular, is that patients can be cared for in their home where they're in charge, as opposed to in the clinic where the nurse is in charge. And it really helps, and they work, the referral network members are trusted members of the community. Just to outline their functions, they help with tracing of patients, with contact tracing of TB contacts that patients have been in touch with adherence support, encouraging counseling and testing and TB screening. And a real win for South Africa recently has been that the Department of Health has now approved and made legal that lay workers can do needle prick testing. So we can now do counseling and testing at household level, starting where people, where there's already some people who are TB and HIV positive. They initiate sputum collection, and in our district, the referral network takes sputum cups into the homes, and in that way also encourages sputum testing. Also collecting sputum specimens for people who have completed treatment. They link patients to other service providers as is needed and as there's interest, involve in community and largely DOH-initiated community mobilization activities. And for World Vision, with our child focus, what I'm really proud of is the amount of children that they refer for prophylaxis that otherwise might not get onto prophylaxis. Some of the results, those of you who know TB work, and a 2-year program time frame is very short to get results, but we have been able to, there's evidence of HIV testing in new TB patients over 12 months increased from 78 to 87%. And those that get to the VCT, there's more than 97% that know their outcome and act on the outcome of their test. Sputum testing has also increased over the 2 years. You can see the figures. Interruption, there's a decrease in the treatment interruption from 8.6 to 6.9% over 12 months. And when we did a random survey of clients at household level who were visited by referral network members, and one of the things that they said that the visits and the interaction at household level helped to decrease the stigma and made it easier to be open about their status in the home, and that it really helped to improve their knowledge of TB, HIV, and the relationship between the two diseases and how to live positively and to complete treatment. And the referral network also, a number of them are traditional healers. And so it increased the social capital, and I'll share more even what we did with the taxi drivers. Another intervention, because of the high poverty and food insecurity, we initiated, at the request of patients, household gardens. The most vulnerable patients were identified with the clinic, and so one, they were identified. Two, they were trained in gardening, and it's trench gardening. So, and 100 patients were assisted with gardens, 36 of them on ART, 30 on TB treatment, and 34 were co-infected. Again, we did survey, random survey, and interviewed patients intensively. 71 said that they had experienced health improvement. 99 one patient died. The rest of the patients with gardens used food to feed their families and themselves, and 49 were able to grow enough to sell the surplus and improve their household income. Another initiative which we implemented was TB HIV messages were given at household level during pension days at all primary schools in the municipality and within DOH campaigns. But the intervention which was innovative was taxi messages. We designed taxi messages in local language, and with the cooperation of the taxi drivers, placed them in taxis. Didn't have enough days in which to do it, but out of about 50% of the taxis carried messages, and we did, again, as random interviewed passengers in taxis to see how they reacted or if they even saw the messages, and 61% of the passengers read and reflected on the messages, and a number of them said that because of the messages, people covered their mouth, and windows were open. So as you know, taxis are an incubator for HIV or TB transmission. And what was really striking was the taxi drivers wanted to be trained more in TB, and they said that they care for their passengers, and some even said that when they had ill passengers, they would take them to the hospital, and they wanted to have a training at the taxi rank while they were waiting for passengers. So lessons learned. Existing health structures can effectively be equipped with knowledge and skills on integrated TB care and prevention and treatment support. You can coordinate within, we found it very effective to work within clinic catchment areas and liaise directly, because clinic catchment areas keep in touch with the patients largely within their catchment area, though there are mobile patients. Households are a very effective context for addressing barriers to adherence, challenges, and also for TB and HIV screening. Challenges, with a number of NGOs working in the area, you need to work hard to prevent duplication of efforts. Difficult to track the impact on treatment outcomes because the time frame was short. Lack of stipends of some of the referral network led to attrition, but we're working on this in building community-based organizations within the healthcare, community-based healthcare cadres of workers, so that they can, in South Africa there are resources available. So we hope to be able to address the issue of stipends. Staff shortages led to challenges with facility nurses being able to properly coordinate the monthly meetings. Mobile patients gave us challenges, and we need further evaluation on the TB outcomes. The future, I think the referral network model is scalable. Stipends need to be addressed. We are looking forward to using cell phone technology to improve the data between household and community facility level. I've mentioned taxis are a good, taxis in schools for social mobilization, and we've been able to equip a local NGO after the end of the grant to continue to take over the coordination of the referral networks, and handed the partnership with the Department of Health over to the local NGO also. Thank you very much.